Esther Velilla from Spain. She'll be speaking on how to avoid complications in ART through pre-implantation genetic diagnosis. Esther Velilla holds a doctorate in genetics and cell biology from the Autonomous University of Barcelona. She obtained the Senior Clinical Embryologist certification by ESHRE and the SBIR certification in Assisted Human Reproduction Clinical Embryology. She moved to the United States to join the Institute for Reproductive Medicine and Science at St. Barnabas Medical Hospital and Reprogenetics, where she began her work in the field of PGD. She returned to Spain 2 years later, hired by Institute Marcus to create the PGD service. She is a co-founder of the Center for Embryo Medicine, a genetic center specialized in pre-implantation genetics diagnosis and the genetic diagnosis of male infertility, offering their services to assisted reproduction clinics. She is currently the director of the Reproductive Biology Service of Institute Marcus, coordinating the IVF, andrology, and PGD laboratories, as well as director of the Center for Embryo Medicine. Since June 2010, she is the president of the interest group in genetics and reproduction of the Association for the Study of Reproductive Biology.
Coming from IVF, present chromosomal abnormalities. 30% of the embryos that we have in culture can have chromosomal abnormalities. And these chromosomal abnormalities has been related to poor quality embryos. The embryos that present worse quality are the most prone to have chromosomal abnormalities. If we check the embryos that present more than 35% of fragmented cells, we can find that those embryos present like 70–90% of chromosomal abnormalities. And the ones that arrive to blastocyst stage, they already have that. We cannot select the embryos that arrive to blastocyst in order to have a pregnancy, because a good blastocyst can be trisomic, can have polyploidies, or can be a mosaic. Apart from that, we know that output embryos, the good-looking embryos, can be abnormal also. They can be a trisomy. And there is a high incidence of chromosomal abnormalities in advanced maternal age and genetic malfactor. I want to focus in these two main groups that are the main groups that present chromosomal abnormalities. When we have a long count sperm, 30% of the patients that has low sperm count number present chromosomal risk, and this is translated in 70%, or less 60–70% of chromosomal abnormalities on the embryos that these patients will generate. So it's logic to think, with all that scenario, it's logic to think that if we can select the output embryos to transfer, we can increase the pregnancy rate, we can reduce the miscarriage rate, and we can increase the take-home baby rate. And more than that, we can reduce the risk of having to choose for a therapeutic abortion at the end of the first semester. But what is really happening? I'm not going through all the data that there is on the literature, but just to let you know, we have been published a lot about the benefit of prenatal genetic screening during this last year. But in 2007, all the studies that came out at the first site were non-randomized, because in a private clinic, it's very difficult to do randomized clinic if you know the risk of having these chromosome abnormalities. But in 2007, it came out a work from Massenburg that it makes a change in the PGD field, because in this work, they published that PGD was not benefit from infertility patients, and PGD was harmful for these patients. So from that point, we start, there were a lot of literature that came out saying that probably it's not harmful, but there is no benefit from this kind of population. So what was really happening at that time is that we cannot do magic with PGD. So PGD is not just analyze and transfer in the embryos. We need all the change completely perfect in order to have the good potential of this technique. At the first site, we need to select a good candidate for PGD. We can do PGD to all people, but we have to focus what we are going to look for. For example, if our target is to increase pregnancy rate, we can offer PGD as elective or we can offer PGD to IVF failure candidates. But for that, we will need a high number of embryos, because just analyzing, we are not doing anything. We need to analyze, to check out the embryos that are employed, and with that, we have to select by morphology also. So in that group of patients, what we will need is to do two things. First, to select for chromosomal abnormalities, and then to select by morphology. If we do that, we can increase pregnancy rate. But not PGD is only to increase pregnancy rate. We have some groups that they just need a healthy pregnancy. I'm talking about recurrent miscarriage, genetic malfactor, or IVF, advanced maternal age. These patients have high risk of chromosomal abnormalities, and what they don't want is another miscarriage or another failure. So in that terms, in that group of patients, what we are looking for is a healthy pregnancy. If we have one embryo or we have two embryos, we can analyze it and we can transfer if there is some embryos to the woman. But in that group, a specific group, we are not looking to increase pregnancy rate. What we are looking for with the PGD is to give them a healthy pregnancy. What we have to optimize apart from that is all the stimulation process. We need good stimulation process with good quality of oocytes, good laboratory IVF. We need good conditions in the laboratory that permit us to move the embryos to blastocyst stage. If we don't have blastocysts, the chance of having a pregnancy is very, very low. And we need, at the end of this point, a good transfer protocol. And in this chain also, what is important is to have a good PGD technique. We have to perform the biopsy in a proper hands. There is no way that we can lose any embryos or lose any nucleus during all the process. If the process is performed proficiency, there is no harm in the embryo, there is no damage, and you are not going to lose any embryo. So it's very important to have the right biopsy. There are 3 different techniques on the market. We can biopsy by laser, by acid thyroid, or mechanical. Doesn't mind the technology that you use. The important thing is that you use it properly. We need a good fixation and tubing protocol, depending on the technique you are used. As I said, we cannot lose any nucleus. If we lose a nucleus or we use one cell in the tubing, it means that we are going to lose an embryo to transfer, so that's unacceptable, and you have to optimize that a lot. And then we need a good technique that analyzes with the minimum error rate that's possible. So if we have that, we can say that probably we can have different results. And let me show you this late prospect randomized control study that came out recently, that they performed all the parts of the chain completely proficiency, and they had this increase in pregnancy rates and implantation rates and the reduced in spontaneous abortions, analyzing all the chromosomes. So, but there are the 2 points that we cannot avoid with PGD. We have 2 main limitations. The first one is the mosaicism. It's a natural process, randomized. We cannot control it. We cannot analyze the embryo every single day. We just can analyze the embryo once. So what happens with the mitotic errors after that, we cannot control that. But what we control is the second limitation, that's the number of chromosomes analyzed. But that time, 2-3 years ago, we were in a moment that we just can analyze 9 chromosomes. So our question was, what's the real limitation that we are having in terms of increase the pregnancy rate? Is for the technique or is for the number of chromosomes that we analyze? So at that point, all the PGD groups has focused in developing a technique that can have results in 24 hours, that there is no DNA damage, that we can analyze all the chromosomes, and that the technique has an error rate that is compatible with the PGD guidelines. So a lot of techniques came out in the market. We have the comparative genome hybridization techniques, microarrays-based ones, by bags or SNP arrays, qPCR, cariomapping, and the new technique that it's now going on, that it's new generation sequencing. And apart from that, the fish that permits to optimize 24 chromosomes. At that time, well, if we take into a look of this, and we have to see which technique is the best for us. Most of the techniques that came out has technical validation. The technical validation has been published. They can the first two ones that are based in, they start with whole amplification, genome amplification. They can, well, they are directed to analyze aneuploidy screening and chromosome rearrangements, but since they start with whole genome amplification, you can split the sample in two, and you can also analyze if, monogenic diseases if it's needed. Then you have qPCR, karyomapping, that it's not coming on, that you can use the same technique to do monogenic diseases also. And finally, the FISH technique, that the main limitation is that you cannot use it for monogenic diseases because you are going to fix one nucleus. This nucleus is going to use it for pre-implantation genetic screening. If we look at the efficiency of the technique, the techniques that start with whole genome amplification, they have 5% of embryos without diagnosis because it's the limitation of the whole genome amplification. So that means that we cannot transfer that embryos. This is a mistake. This is, well, it's not that the embryos has 50% of of non-diagnosis, obviously. Is that with a SNP arrays, 50% of the SNPs are not informative. So you will need a big software system to remove all this data and to finish and to check the data that you can use for the analysis. But arrays, bags or arrays SNP, they have this 5% of non-amplification. FISH24 is 1% of non-diagnosis. We will see it later. And then the efficiency that they publish from different techniques are quite similar, 96, 98%. The time of analysis varies between 24 to 48 hours, so it means that we can use it for fresh or frozen samples. And here I put it that because depending on the kind of PGD you are performing, you will have to think about which technique is best for your center. It's not the same as center that has its own PGD laboratory that can analyze at the same time. That probably you can use a technique that has a turnout of 24 hours. But if you are a center that you are sending the cases outside, in outside center, and so you are doing transport PGD, you will need more time. So in those cases, you probably will have to freeze the embryos. If you don't want to freeze the embryos, then you will have to check the technique that will adapt to you. So I think that's a global scenario, but each laboratory, depending on its conditions, they have to show the technique that is best for themselves. The cost of the techniques, as you can imagine, the molecular techniques are expensive now because, well, they are new and commercial brands are expensive now. And probably the more average one is FISH24 chromosomes. And the pregnancy rates that all these techniques are giving us are quite similar. We'll see later on. So with that scenario, it came out in the literature a lot of publications that compare the use of FISH9 chromosomes to the PGD, to a technique that can analyze 24 chromosomes. But for me, that comparison of this here is not fair. You have to be careful when you check the literature. Because to compare a technique that can analyze 9 chromosomes to a technique that analyzes 24 chromosomes, there is no point on that. You are comparing two completely different things. So the most fair comparison for me is that one here that compares different kind of 24 chromosome screening techniques. If we take a look into different clinical results, you will see that doesn't mind the technique that you use. More or less, the pregnancy rates that you can get are quite similar, from 40 to 60%. You have to take into account that the pregnancy rates are not just for the technique, as I said before. There are a lot of things that can interfere in this pregnancy rate, and the culture conditions and the technique, the stimulation protocols are very important in that step. So we decided at that time in Instituto Marqués to go through the technique that it was low cost, because our idea is to offer pre-implantation genetic screening to all the population that has chromosomal risk, not just the population that can afford some, therefore, high techniques. So we developed the PGD, pre-implantation genetic screening by FISH for 24 chromosomes. We biopsy, I will explain you how it works. We biopsy the embryos on day 3. Then we perform 4 different panels with oligonucleotide probes. That this kind of probes can have they have a hybridization time very, very low, so you can do it in the same day. Then you have 5 and 6 2 more panels that we use back probes, and then we have 2 more rounds for telomeric probes, because it's very important in FISH technique. What we are having sometimes is non-informative for some specific chromosome. You have to take into account that we just target one point in the chromosome. So if that point fails, we don't have diagnosis for that chromosome. Sometimes we have a normal embryo, but it's non-informative for a specific chromosome. At that time, it's very important to reanalyze this embryo by other telomeric probes. That means that other probes that mark other sides of the chromosome. So you can have diagnosis and you can transfer it. And finally, we transfer the embryo at day 5. So in our hands, we choose that technique because it's low price. You can offer, as I said, you can offer to all population. We solved the problem that we had with the standard technique by FISH, and we are not damaging DNA. We are not losing DNA. And we can have results in 24 hours, so we can do it in a fresh cycle. So at that point, we start the validation of the technique. What we did is to have all the cases that we perform by 9 chromosomes, that we, at that time, we biopsy on day 3. We do pre-implantation genetic screening for 9 chromosomes, and then we take another second group, that's the group that we test for 24 chromosomes. We transfer the embryos that were employed, and then we leave the abnormal embryos into culture until day 5. On day 5, in the group of 9 chromosomes, we fix all the embryo, and we reanalyze all the embryo with 9 chromosomes, and in the group of 24 chromosomes, we fix the whole embryo, and we reanalyze the whole embryo with 24 chromosomes. And here you have the data. We have 107 cases in the FISH 9 group and 111 cases in FISH 24 group. The average nucleus that we analyze per embryo at day 5 is 25 and 29 and 26. And we define 2 differences of error rates. If you take all the papers in the literature about validation of the technique, the error rate, all of them talk about what we call global error rate. What it means that? I mean that if I diagnose an embryo at day 3 as abnormal, in day 5 has to be abnormal. If I diagnose it as normal, at day 5 has to be normal. That's what most of the people look when they validate the technique. But we don't stop here, we go further, because what we wanted to know is that if the same abnormality that we find on day 3 is the same abnormality that we find on day 5. And that is what we call pure error rate. If I find a trisomy 13 on day 3, has to be a trisomy 13 in the global embryo on day 5. So the global error rate that we have with PGD 9 chromosomes was 2.8, and the ones that we are having with 24 chromosomes is 3.6. And if we look into the pure error rate, the pure error rate for FISH 9 is 2.8, and for FISH 24 it's a little higher, it's 5.4. Here you have the misdiagnosis embryos. If we take into look at 9 chromosomes first here, you will see that here we have a false negative. It's a normal embryo that we classify the embryo as a normal, and then it's found that it's trisomy 22 on day 3. And we have the other one embryo that was a trisomy 13 that came out to be normal, and an embryo that was XXX that came out to be normal also. If we look into PGD 24, we have 4 different misdiagnoses here, where we have trisomy 15, it was normal, X0 and it was normal, trisomy 15 and it was normal, and monosomy 15 and it was normal. But we have 2 more misdiagnoses that we call pure error rate. So that means that this abnormality here we find out to be here. You will see that this is a no-plot cell line here. That's going to be a no-plot cell line here. And in this case, here we have multiple chromosome abnormality, and we find out on the whole embryo that it is just the monosomy, the trisomy 22. So what I want to say that with these numbers is that at the beginning we thought that the error rate will increase so much with the numbers of with the number of chromosomes analyzed, and no, this error rate is independently of the chromosome number that you analyze. So we start the clinical validation with clinical patients, and one of our main concerns is that probably the misdiagnosed, the embryos that don't have diagnosis will increase, and the embryos that cannot have a transfer will the patients that cannot have a transfer can increase. And what we found out is that the embryos without diagnosis were similar, analyzing none or analyzing 24, is 1.7 and 1.9. And what is true is that we are finding a lot of embryos that we cannot transfer because they are chromosomally abnormal. What is really happening is that 26% of the embryos that we have for a patient present some abnormality that would have been detected with 9 chromosomes. 51% of the embryos of one patient present some abnormalities that we can detect with fish 9 chromosomes, but this means that they are with some other abnormalities that could also be detected with 24. But all these embryos here we detected analyzing just 9. And that's important data. What was happening is that we were missing 23% of the embryos. 23% of the embryos present some chromosome abnormalities that we cannot detect with 9 chromosomes, and the only way to detect it is if we analyze all the chromosomes. And that's the embryos that we were transferring, we had no pregnancy. So here's the first clinical data from the first year with working of the technique. You will see that we have a positive pregnancy rate of 60% and ongoing pregnancy rate of 40%. So at that point, we consider the technique a very useful technique in order to offer PGD to all couples. The technique allows us to perform a lot of runs without losing DNA, and the error rate is completely compatible with PGD guidelines. The group of patients that we are including in our group of patients candidates for pre-implantation genetic screening are advanced maternal age, recurrent miscarriage, genetic male factor, when we have an abnormal spore-fish or meiotic pathology, a male factor. Consider that you have to consider that 30% of these patients that has local number will present a genetic male factor, and 4 patients that present chromosomal enlargements on the somatic karyotype. So look now at the data that we have until August 2013, this here. We have increased the positive pregnancy rate from 60 to 65 and the ongoing pregnancy rate to 57. And we did that because we have to improve a lot the IVF culture conditions, And what I say at the beginning of the talk, it's very important not just analyze. It's very important that all the chain from the beginning to the end is performed properly. If we don't have blastocysts, we cannot have a good pregnancy rate. And if we compare that to the clinical results that we have with 9 chromosomes, you will see that we significantly increase the pregnancy rate, the clinical pregnancy rate, and we reduce and we increase the ongoing pregnancy rate. These data are from the group of patients with advanced maternal age. Consider that these patients don't have a lot of embryos. We cannot select by morphology. Some of the I have not put here the mean number of embryos analyzed in this group of patients, but we are having 3-4 embryos per patient as maximum, so as average. So here you have that we can have a positive pregnancy rate of 60%, clinical pregnancy rate of 54%, an ongoing pregnancy rate of 45%, and all data is a statistically significant increase comparing to the standard technique that we use for PGD with 9 chromosomes. And this is the group of genetic factor. We include 110 patients. We have a significant increase comparing to 9 chromosomes in positive pregnancy rates and in ongoing pregnancy rates. So to conclude, just another time, PGD 24 chromosomes is a low-cost technique that can be performed easily, can be applied to all people, all candidates to IVF. We find out to have an increase in pregnancy rate, an increase in the ongoing pregnancy rate, but I repeat again, we need blastocysts. If we don't have blastocysts, we cannot have a good pregnancy rate. And thank you so much.